Thank you for joining us for today's informational webinar on the hospital discharge data system. Our agenda today will be having introductions. We will also have the processing of hospital discharge data, data availability, submitting HTDS data requests, using data, discussing HTDS data needs. Who are we? We are the Office of Healthcare Statistics in the Division of Population Health Assessment in the Tennessee Department of Health. My name is Jenny Rose Kokoti. I'm the Director of the Office of Healthcare Statistics. We have Daniel Merchant on my team. He is the manager of the Hospital Discharge Data System. We have Nerissa Harvey, who is the Assistant Manager for the Hospital Discharge Data System. We also have William Gribb, who is the manager of the Ambulatory Surgical Treatment Center and Outpatient Diagnostic Center Data System Management. We also have Brian Metzger here today with us. He is the Senior Vice President of Information Services with the Tennessee Hospital Association. Thank you, Brian, for being with us here today. So what is the Hospital Discharge Data System? Tennessee law requires all hospitals to submit their UBO4 claims data on all inpatient and outpatient discharges to the Department of Health. The rules of the Tennessee Department of Health state clearly what will be submitted by the different hospitals. The requirements are further listed in detail in the rules, and the HTDS user manual gives the descriptions on how this data will be provided. And here is the link to the user manual. Here's the beginning. Sorry, I have been informed I am not sharing my slide. I'm so sorry. So here are the rules of the hospital discharge data system. What are the program goals? To collect and summarize UBO4 hospital claims data from licensed hospitals in the state of Tennessee. We also analyze and compare similar types of services to promote a more price competitive environment in the medical marketplace. We examine data to gauge the delivery of healthcare services to patients, and we produce various reports. So what do we use to collect the data from? The data we get from the hospitals is on the UBO4 claim form. Each form contains patient diagnosis, procedures performed, charges for services provided, and select patient demographics. In the information you received today, you should have received a copy of a sample UBO4 form that tells what data information is collected on the claim form. Who reports data to TDH? Acute care hospitals, psychiatric hospitals licensed by TDH, rehabilitation hospitals, specialty hospitals, mental health hospitals licensed by the Tennessee Department of Mental Health Services. They began reporting data to us in 2018. We did not receive data from the Veterans Administration, but they have reported voluntarily in the past. And here is a map of the acute care hospitals by county in 2018. Do we have any questions? All right, we will open the first polling questions. And the first question is, how many hospitals reported data to the Tennessee Department of Health in calendar year 2018? The second question is, which Tennessee county had the highest number of acute care hospitals in 2018? So basically we have about 2 minutes. We have a little less than a minute before we close the poll. So we have our results, but here's the answer for you. So we have 168 hospitals that are currently reporting to the Tennessee Department of Health. And the second question, Shelby County had the highest number of acute care hospitals in 2018, followed by Davidson with 10 hospitals. Hamilton and Knox both had 7. I will now go ahead and invite Narissa Harvey to share her presentation.
Share screen, please.
I'm working on it. Go ahead. Okay. It seems we have technical difficulties with Narissa, but I could let Brian, do you feel comfortable sharing? Okay. I think, Brian, you should have privileges. While Brian is setting up, we have a question in the chat that's asking, are outpatient data from those acute hospital only? Yes, because not only acute, but also from rehab and psychiatric hospitals. But mental health hospitals only provide us inpatient data.
Generous, are you able to see my screen at this point?
Yes.
Great. All right, I will jump in. So for those of you I haven't met, my name is Brian Metzger. I'm the Senior VP of Information Services at the Tennessee Hospital Association. Joined, Larissa Lee is on the line as well. She is the director of our, what we call our Health Information Network. So THA founded the Health Information Network back in 1999 to assist our member hospitals in meeting the state reporting, the discharge data reporting requirements that Generosa just covered. We contract, like to do that work, we contract with the Hospital Industry Data Institute, what we call HIDE, which is a data division of the Missouri Hospital Association. And specifically what we're contracting with them for is their data collection platform, which they call HeidiNet. THA currently processes discharge data for 138 of our member hospitals. Those are hospitals that are members of THA. And again, those hospitals are submitting their claims data directly to the HeidiNet system. And we'll talk a little bit later about the types of reports that they get back and that you all also, or sorry, non-member hospitals also receive. So, and then also for the majority of those years, we've also partnered with the Department of Health to process discharge data for what we call non-HIN hospitals or hospitals that are not members of THA and thus submit their data directly to the Department of Health. And there are about 25 of those that we're processing data for. So as Generosa mentioned, hospitals are required to report inpatient and outpatient discharges. It's UB04 data. And that data is reported each quarter. We break those two high-level types of data into 5 different data sets. The first of those is inpatient, and that's defined by bill type. And the other 4 are outpatient data sets that are typically defined by revenue code. Those are ambulatory surgery, emergency department, observation. There are selected diagnostic services, things like lithotripsy, PET scans, CT scans, etc. The only of those data sets that has a pretty complex definition is the ambulatory surgery definition. It's defined by a combination of bill type, revenue code, and CPT and HCPCS codes. And so essentially, we look at each of those fields on the UB04 claim, and if it meets a certain set of criteria, it drops into these different buckets or different data sets. One quirk is that a given claim can actually meet various definitions. And if you think about the way patients are interacting with hospitals, that probably makes sense. So for example, if I have an episode with my back and I show up at the emergency department in a lot of pain, they might bring me into the emergency department, and thus I'm going to have on that claim, I'm going to have a revenue code associated with that emergency department encounter. A few hours later, I may be admitted to the inpatient side or may be admitted for observation, and thus my claim for that visit to the hospital would meet both of those definitions. So it is important when you're analyzing data to ensure that you take that into account. You can't necessarily aggregate or count across these various buckets to get a sense of total number of patients. You kind of have to do that slightly differently. So to talk through the data flow process, and this is specifically for non-THA member hospitals, and so I'll walk you through how that process works. For hospitals that are not members of THA, they submit their data directly to the Department of Health. Members of Generosa's team perform data checks on the data that's submitted to make sure it meets certain requirements. And once it passes their data check, they provide that data to THA via a secure file transfer process. Once we get the data for all those hospitals, members of my team and Larissa's team upload that data to HeidiNet, again, the same data processing platform that THA member hospitals submit data to. And to give you a little bit of sense of what HeidiNet is doing, basically on each individual claim that is submitted, it's analyzing the 276 plus fields that are on that claim to meet certain criteria. And so we have a total of 279 different, what we call fatal error edits. Those are edits, or I'm trying to think of another descriptive term for that. I mean, essentially what we're doing is looking at a specific field in the database and saying, it needs to meet this a certain criteria. And these fatal error rates, or sorry, fatal error edits, if a field on a record flags as a fatal error, so it's not meeting the criteria. Let's say it is left blank and it is a required field, or if it's a payer code and it doesn't, the payer code that the hospital submitted on this claim doesn't meet the list of valid payer codes, then we would flag that specific field as having a fatal error. But then secondarily, we would also flag that entire record as having a fatal error associated with it. And the state law and the rules associated with that require that hospitals that are submitting this inpatient and outpatient data have a less than 2% fatal error rate. And so the system is not only flagging those, but also keeps up with, if there were a total of 1,000 records submitted, it ensures that no more than 2% of those records have a fatal error associated with them. We also have 81 different what we call warning edits. These don't count against the fatal error rate, but it's essentially feedback that we're providing to the hospitals that are submitting this data to let them know that something associated with that particular field looks to be off, i.e. it's not meeting the criteria for that field that we have set up. But it doesn't necessarily count against their fatal error rate, but it can provide some useful information back to the hospital to improve the quality of their data. So once HIDINET processes a data submission, a file that a hospital has submitted, or in this case that the THA staff person has taken the file from a non-THA member hospital, submitted it to the system. We look at a set of reports, and I'll walk through these two different reports to look for potential issues with the data. The first of those is what we call the edit detail report. This is kind of a high-level report, but it also has some granular data as well. It looks at the data by inpatient and outpatient, gives you a total count of the number of each of those types of records that were claims that were submitted by the hospital, and then breaks down the fatal error rate associated with each of those two data sets. Further in the report, you get a detailed, like record level detail of the individual claims or records in that data set that had a fatal error associated with them. This is very helpful when you're working to improve that fatal error rate. You can pretty easily scan through that and identify the types of errors that are occurring. And oftentimes the issues that we have is the hospital's operating from an outdated lookup table, or they're not providing a certain field that they need to be, and this particular report can help that jump out at you and can assist you with getting that error rate below the 2%. Again, this report also lists the various warning errors that are live in the system. The next report is what we call a verification report. This report is really useful for understanding the context around the data. So it includes a lot of historical data for that same facility. So basically what the system does, or what this report does, is it looks across 19 different metrics or aggregations of data. These are things like charges, payer distribution, the point of origin code, discharge status, patient zip code. And what it does is it'll be a relatively simple breakdown of that hospital's data by those various metrics, and then it provides historical context. So this is really important that you analyze these reports, because it can give you a sense of is what has been submitted in this most recent submission in line with the historical perspective for this hospital. So oftentimes what we see here is maybe a hospital experiences an EHR upgrade or change, and suddenly maybe their inpatient admissions go from typically say 2,000 per quarter down to 500 per quarter. Well, you might not catch any fatal error issues. The data that is being submitted may be perfectly valid, but the volume of discharges by any of these various aggregations may be way off. And so that assists us when we work with hospitals in better understanding what's going on. And sometimes there are valid reasons for that change in volume. For example, a physician, a high volume physician may retire or may go to another hospital or may move out of state. And so the hospital all of a sudden stops providing a certain type of service. And so this report helps to identify some of those potential issues. So getting back to the process for non-member hospitals, so the members of my team, they again submit that data to Heidi. They analyze those two reports at a pretty high level for each hospital, and we flag any hospitals that have a fatal error rate above 2%, and we do a check of that reasonableness on the verification report to see if we see any major shifts in volumes. And then what we do is we package up the edit detail reports and the verification reports for each hospital, along with a high-level summary report that lists each of the individual hospitals and their error rates for inpatient and outpatient. And we flag again those that are above 2%, and we send all that securely back to the Tennessee Department of Health staff. And then they work with you, they distribute that information back to those hospitals and coordinate resubmissions. And Narissa will kind of talk through that process and specifically the timing for all of that and the work that they do to work with hospitals momentarily. Again, what I've kind of described for you in detail is how non-THA members interact and submit their data and what we do to process that. For hospitals that are members of THA, again, they're interacting directly with the HeidiNet platform, so they make direct submissions to the website. Their staff get these same edit detail and verification reports pretty quickly after they submit their data, so that they can analyze, look for any issues, monitor their 2% fatal error rate, and all those sorts of things. So I think that's it for my presentation. Happy to answer any questions.
Thank you, Brian. We do have one question for you, and the question's asking, I'm sorry, it's about what does DRG stand for?
So it stands for Diagnostic Related Group. I believe that's right. And that there are a couple different classifications. The one that we use is MSDRG, which is, I shouldn't have volunteered that information if I couldn't come up with the definition. It's essentially Medicare's grouping, and essentially what you're doing is you're looking at each claim, and MSDRG or DRG relates specifically to the inpatient data set. Larissa just messaged me. It is Medicare Severity Diagnosis Related Groups. That's MSDRG. And essentially what the MSDRGs do is they take an entire claim or an entire visit and they try to roll it up into a risk adjusted grouping so that similar types of claims or interactions with the hospital can be grouped together and analyzed. And it's a pretty well documented, and it's been around for quite a while. But it's also affiliated with how hospitals are paid for the types of procedures that they provide as well.
Brian, if you'd stop sharing, then we'd have more questions later, and
Okay.
we'll have Narissa's presentation now.
Great.
Narissa, are you able to upload your document? Let me make you the host.
I believe Brian is still sharing right now. I will try just as soon as Brian
Okay.
Sorry, I thought I had turned it off.
stops sharing.
All right. Narissa, you're now the presenter.
All right. All right. Can you see my screen right now?
Not yet.
Okay. Hmm. Okay, let's go back. Generosa, would you share my screen and I'll go ahead and do my presentation. Would you please do that for me?
Yes. So please stop your privilege.
Okay. Let me get back into it. Okay.
Okay, Narissa, go ahead.
Okay. Okay. Um, is okay, you're sharing the screen for me?
I should be sharing the screen for you. Yes.
Oh, okay. On slide 1. Okay. Okay. Slide 1. Processing hospital claims data for the hospital discharge data system. Hello, everyone, and welcome to the hospital discharge data system informational webinar. My name is Narissa Harvey, and I am the assistant manager for hospital discharge data system. I started with the Tennessee Department of Health, HDDS, in 1997. And I will be talking to you today about processing claims data as it pertains to the hospital discharge data system. Next slide. Who reports to TDH? In 1975, the American Hospital Association and the National Uniform Billing Committee developed a single billing form, and it was called the UB82. And the insurance companies were the ones who were responsible for reporting this data to the Tennessee Department of Health. Thus, the Tennessee Code Annotated 68-1-108 laws was enacted, and in 1994, it required all hospitals, except for the federal, the mental health, in the state of Tennessee to submit their UBO4 claims to the Tennessee Department of Health. However, as of third quarter 2018, all mental health hospitals in the state of Tennessee are now reporting data according to this revised law. Next slide. So how do hospitals submit UBO4 patient data? Here are two ways that the hospitals can report. They can either report through our partner, Tennessee Hospital Association Health Information Network, and you just heard from Brian, or they can report directly to the hospital discharge data system. Hospitals reporting through THA are referred to as HEN hospitals. Hospitals reporting directly to the department are referred to as non-HEN hospitals. Next slide. So, when is the data to be submitted? All hospitals must report their data 60 days after the end of each quarter. In other words, both HEN and non-HEN claims data are due on the same date. And as we look at our quarters, the data submission date after each quarter, May the 30th is the first quarter that the data is due. The second quarter, August the 29th. The third quarter is November the 29th. And the fourth quarter is due March the 1st. These dates will remain the same, even if there is a leap year. HDDS will send a 30-day notice to all non-HEN hospitals, alerting them of the upcoming due date. Hospitals may report earlier if they wish. This year, I would like to say during the COVID crisis, all the hospitals, both HEN and non-HEN, were phenomenal with reporting their data. Non-reporting of data without a request for extension of reporting can and will result in fines and penalties for that facility. Next slide. What do the hospitals report to TDH? Each file is submitted separately as an inpatient and outpatient file to TDH. We collect about 276 data elements, and most of these are from the UBO form. However, some such as the social security number or race, ethnicity, total amounts, things like that, they are not on the form. However, our manual lists all the variables that must be reported. Description of the variables, formats such as the field width, and if the field is numeric or character, and other useful information to help the facilities send the data in the correct format. Next slide. So what initial data checks do we make? As I stated before, we do have them to send the data in separate inpatient and outpatient files. We check the quarter and the year, and it must be correct for that quarter reporting. There have been a few occasions where the wrong data was submitted, and they have to submit the right data. The record length must be 2538 bytes long, and the 5-digit state assigned ID for that facility must be in that file. And this helps us to properly identify the facility. We reconcile the inpatient and outpatient counts of the submitted data with the PH 3924, which is called a transmittal information sheet. And this, we ask this to accompany each data submission. Certain variables are checked for appropriate coding, missing or incorrect values. If a variable exceed or field exceed 2% in the error rates, then the data is rejected. We will send a written letter to the facility to tell them the problem, what variable needs to be corrected, and we will ask them to correct and resubmit that data within 15 days. Again, failure to do so can result in penalties and fines. Next slide. So what additional checks are done? Our partner, Tennessee Hospital Association, does a deeper check of errors. Example, the patient's gender is coded as male, but the diagnosis says hysterectomy. That is a fatal error. So these edit reports give both the fatal error and the warning errors. We stress to the non-HIN hospitals that the fatal errors over the 2% margin be corrected and resubmitted, because it is our goal to get as accurate information as possible. Another check that the Tennessee the Tennessee Health Association helps us with is the provisional reports. And these reports are sent out to all HIN facilities. And these the provisional reports are formal verification for the hospital before the release of data. It shows the total number of records by primary payer for each quarter. These reports will occur 4 times for the reporting year, and hospitals may replace their data during the provisional report time. Then we have what's called the final verification reports, and this is also sent out to all HIN and non-HIN facilities. These reports contain the final 4 quarters for the year, so the hospital can look at them, or that can be replaced during the provisional reports. During this time, the final verifications is going on. Hospitals may not replace data during this time. Next slide, please. Our process flow. So here's the gist for the non-HIN process flow. All non-HIN hospitals report their data to TDH 60 days after the end of each quarter, per the previous mentioned schedule. If the data is correct, and according to our criteria that we check them for, the file is ready for submission to THA. If it does not meet the criteria, the data is rejected, and the hospital is asked to correct and resubmit their data within 15 days. Once all non-HIN data is submitted correct, then send it on to THA, and the edit reports are created. THA then sends us back the edit reports for that quarter. After all corrections have been satisfied, they've been corrected and resubmitted from the edit reports, HDDS receives all HIN and non-HIN data from THA, and we start the quarterly provisional reports on through the final reports. Are there any questions?
There's a question for you, Marissa.
All right.
What is the purpose of the maximum record length of 2,538?
All right. The purpose is that when we have set the variables and set the length, it cannot go beyond that. If it does, it will cause the other data to be pushed it'll be pushed out, be like squeezed out to the edge or to the side, and it is not correct. Also, when we set the variables what are to be reported, we set the length so that everybody will send their data in one record length.
Do we have any more questions? Okay, then we shall open the polling for the next set of questions. So the question we're asking is approximately how many inpatient records did HTDS receive for 2018? And approximately how many outpatient records did HTDS receive for 2018? So take a wild guess. We have half a minute before we close the poll. Okay, I think it's about time. So we have our answers. We have 1 million records for inpatient that we received in 2018 and 4.5 million outpatient records from HTDS. So we'll continue with the next part of our presentation, data availability. How many years of data do we have? We started collecting data from 1995, and so that's the initial data we have there. So from 1995 until 1999, it was the UB92 data form, but this data from these years may not contain accurate information. So we have underreported variables, for example, race, ethnicity, in both inpatient and outpatient data. And hospitals were not required to report outpatient surgeries or ER visits and 23-hour observations. But beginning the year 2000, our data is so much better. We have a lot more information contained in our data. We're still reporting with the UB92 form until 2006. Beginning with 2007 until present, we are reporting with the UB04 form. When is the latest data available? So reports using aggregate final data may be released to the public at any time. But for the public release, we only release data after 18 months following the close of the data year. So for 2018, the data was available this year, July 2020. So the next public release will be July 2021 for 2019 data. So the timeline to our release basically is this way. So the hospital submit data to us at the end of the quarter after 60 days. A hospital may request a 15-day extension that may further delay processing of that data. But finally, we get the data in either to TDH or THA. And if there are any errors, the hospital has 15 days to correct the errors. At times, they even ask for more time to correct errors. So it could even take up to 30 days to correct the errors from the hospitals. Once the corrections are done, non-HEN data is sent to THA for process, and THA sends that data with the HEN hospital data through HIDE. Hospitals then receive edit reports from THA, and they have 15 days to correct errors. And so once they've corrected the errors, if there are any, we resubmit the data, and then THA processes it and submits all data to TDH. After that, we process the data, add some more variables in there, and send out verification reports. We also do geocoding and uh, other analysis on the data. So once the verification reports go out, hospitals have 15 days to verify the data. And hopefully things are okay. Once the verification is done, then we release the data. So provisional data is released basically after 10 months, final data after 13 months, and public data is we have 18 months before we release the data. Is there a charge for the data? The public is charged for record level data. So basically we charge 300, the rules state that we charge a fee of $300 for a quarter of inpatient and or outpatient data. So for a whole year's data, it'll be $1,200. So whether you ask for a subset of the data or all the data for a quarter, the fee will still be the same, $300. But there is no charge for aggregate data. Are there any questions? Let me check. I don't see any questions, but we can continue then to the next presentation. I will have William presenting, and while he gets ready, we will have another poll open. So we have another set of questions for you. And the questions say, which state other than Tennessee had the highest number of patient discharges in Tennessee in 2018? And the other question is, which Tennessee county had the highest number of out-of-state patient discharges in 2018? We have about half a minute, and then I will share the answer for this. Okay, so here are our answers. Which state other than Tennessee had the highest number of patient discharges in Tennessee in 2018? It was Georgia. And this may not be surprising because a lot of, I think, northern Georgia, there are not that many hospitals. So patients go across the border to use Tennessee hospitals. It is followed by Mississippi, Kentucky, and then Mississippi. No, it's followed by Virginia, and then Kentucky, Mississippi, and Kentucky and Mississippi with Arkansas. Which Tennessee county had the patient highest number of out-of-state patient discharges in 2018? It was Shelby County, followed closely by Hamilton County, and we had Sullivan County and Davidson County in there. So I will now turn over to William Gribb, and he will present. Okay, William, you may share your screen.
Okay, thank you very much. Okay. Okay. Hello, my name is William Gribb. I'm the manager for the data system for ASDC and ODC. I'll be discussing about the process of submitting HDDS data. Hold on, closing the polls. Okay. So anyways, to give a brief overview about the Division of Population Health Assessment, this division is responsible for collecting, analyzing, and sharing data. The purpose of this is to inform health policy and planning. Thus, the health reports related to using thus the health reports related to HCAS data will be provided by this division. Such data will be provided in the following forms: aggregate data or record level data. Okay, there we go. The presentation was not moving. Okay, so to make a data request submission, you would need to go to the Department of Health website, which will be www.tn.gov/health .html. Once there, you would need to click on to, at the very top of the web page, statistical data. Uh, Following that, you would just need to scroll down to the button that's, that says submit a data request. Uh, and the link here is the direct passage to the website. This here is what the submission, the data request submission button would look like once you arrive at the web page. Okay, so once you have arrived at the data submission website, you would first need to read through the welcome page for information on what type of data is available, including field types and their format. Following that, you would need to enter in your contact information and the purpose of the request. Afterwards, you would select the available data sets, such as HDDS or PRAMs. Finally, arriving at finally, you would then acknowledge the data release agreement and sign in the request. And this is what the page would look like. Okay. So after the the request submission, the TDH staff, that's the Tennessee Department of Health, will contact the applicant for verification and for any questions about the request. The data request is then assigned to a program staff for completion, where the staff will try and complete the requests as soon as reasonably possible. Once completed, the staff will send the following: PDF file of the original request, the results of the request, and the fulfillment letter. Thank you, and any questions you have for us?
Uh, there are currently no questions for you, William. If you would stop sharing your screen, we'll move on
Yeah,
to questions.
just okay. Just give me a moment to stop sharing. Okay, hold on. Okay, there we go. Stop sharing. Sorry about that.
Okay.
And
Okay. We do have questions from previous presentation, and one of the question is why is it that data that are considered final at 13 months are not available to the public for another 5 months? And this is because it's in the rules. Our HTTS rules do not allow us to release the data before 18 months has passed at the end of the calendar year. So that is why we did not release it to the public. Another question is, how is the race ethnicity information reported in hospital discharge data? Nerissa, would you like to answer that question?
Yes, the race, ethnicity are numbers, 0, 1, 2, and 3, I believe, for the race. And ethnicity, I believe, is maybe 1, 2, or 9. And that they're reported by numbers according to the HDDS manual. So they have to be reported like that. Thank you.
Yes, we also have a derived race variable that
Yes.
simplifies it to race, like white is 1, black is 2,
Hmm.
and so on. But that's derived from our race ethnicity variable.
Yes.
Okay, I will open for a quick poll. This one should hopefully be poll number 5, number 4, while Daniel gets ready to present. We'll just take a minute on this one. I think it should be hopefully. The question asks, what day of the week had the highest frequency of emergency room visits in 2018? So is it Sunday, Monday, Tuesday, Wednesday, Thursday, Friday? And here I think I'll pick on Brian to see what his answer is like.
I felt so confident about the other ones too. This one is a wild guess. So I'm gonna guess. Well, do you want me to say it?
Yes.
Okay. I'm gonna guess Monday.
Oh, Monday. Okay. Daniel, what's your guess?
Well, I'll give you the guess. I said yesterday was Saturday.
All right. It's not, well, that's good. All right. So it's already past the time limit. I am going to close the poll, and it's closing now. And the answer is Sunday. So apparently most people end up in the ER on a Sunday, and which is not should not be surprising if many urgent care centers are closed or you can't go to your doctor's office. So Sunday is your default place for treatment. And thank you. So I'm going to now let Daniel in a minute. Okay, you may present.
All right. Hi, I'm Daniel, and I've been with the hospital discharge data system since May, when my predecessor, Glenn Baker, retired. However, I've been with the Department of Health, working with health statistics since 2007, and have worked in a variety of programs, primarily behavioral risk factor surveillance system and population, working with it, with weighting, that survey data, and then vital statistics. But I have worked with the hospital discharge data since about 2011, so about 9 years now. So I'm pretty familiar with it, and just want to say I really appreciate Narissa and Generosa and William for bearing with me as I try to catch up since taking over from Glenn in May. I'd like to talk about some basic guidance if and when using the record level data, particularly for data purchases and or these research type requests for the record level data. If we just take a peek at our website, we have these hospital discharge user manuals out there. And probably the easiest way to find them is just Google Tennessee Hospital Discharge. And these include the specific file layouts, the variables, the value possibilities for those variables, and or the ranges for each of the variables. And they're intended for facilities and or vendors that submit their data to us, but they're also useful to programmers that are coding, trying to determine things like counts and costs. Now, listed below there are some Tennessee hospital charge reports, and I'd like to visit those later in my presentation. For the file layout, we can provide the customer record level data in a SAS data set or a comma separated value file. And we have two different versions, as mentioned earlier, the UB92 from 1995 to 2006, or the UB04 from 2007 forward. Some differences, primarily in the file length and the number of variables that are available from the newer UB04 as opposed to the older UB92. For example, the number of diagnosis codes. In the old data, we had one primary and then 8 other possibilities. With the newer UB04, we got 18. Same with these external injury, external cause of injury codes. We call them E codes. Used to be only one field. Now we have 3 that we can look at. And then, of course, the file length from over 1,600 characters in width to over 2,300 in the data files we provide. Also, the diagnosis codes, they changed formats in 1995 from the ICD-9 to the ICD-10. So, and that was on October 1st of that year. So there's a real caveat in using the 2015 data because for a particular diagnosis, the programmer will have to pull from both the ICD-9 code and the ICD-10. They're in the same fields in the file, but the user has to just use care in pulling them. We do have a variable, a DXPX qualifier variable that indicates whether the record is coded ICD-9 or ICD-10, so that can be helpful when working with that 2015 data. The Joint Annual Report ID, or JAR ID, is issued to all registered hospitals by the Tennessee Department of Health in Tennessee. And this is actually a 5-digit code where the first 2 digits are the county location, second 2 are the type hospital, and then the 5th digit corresponds to the health service area code or the state geographic region of the location of that hospital. So if you look at the county codes, they'll range from 01 in Anderson County to 95 in Wilson. And you can see on the slide the different types of hospitals there. And with the hospital discharge, we typically fall back on just the 4-digit hospital ID. And so in this example, the 47 corresponds to Knox County. The 21 is the exact hospital, Fort Sanders Regional Medical Center. Another example, Moccasin Bend, and it has a hospital ID beginning in 33 in Hamilton County, and then the 42 is the next, the final 2 digits of that. Added variables as a part of the data processing, we do add additional variables that make the data more user-friendly to programmers. And these are not referenced in the manual. We have a separate documents for these. For example, the Tennessee resident flag, we just have a Y for yes. Race, as mentioned earlier, summarized 1, 2, and 3 for white, black, and other respectively, 9 being unknown. We also have the infant age in months 0 to 11, beginning with the 2012 data, and then the ER record flag, which again is just a Y if there was a emergency room encounter for that record. And again, this file listing of the added variables is available upon request, and we are currently in the planning stages to elaborate on these documents. There's 2, one for the UB04, one for the UB92, with a bit more explanation. So if possible, we hope to eventually post these documents to the web. Coding considerations. This is pulled from an old program I did in, I think, from the 2012 data. And if you just look at some great care that needs to be taken, if you're programming, you want to make sure that the bill end is coded Y for that indicates the last record of a multi-record bill. So otherwise there could be double counting in your counts. In this example, we just pulled Tennessee residents. That may or may not be the case. By the type of hospitals, acute care hospitals only fall within that certain range. So we look at the substring of the hospital ID, the second two digits, or the final two digits, that is. And then you can also look at a range of hospital dates. Say if you're pulling by heat stress, they would only occur in a certain time of year. And then the thing about the hospital data, it doesn't contain the hospital names. It just contains the codes, either the JAR ID or the hospital ID. So you'll have to pull those in by including a proc format, say in your SAS program, or you could have a separate table that you merge in, or do a join in Access, or even with an Excel file, do an index and match type routine to pull those in and to get those to output in a user-friendly format for you. We can provide that listing for you from our friends in the facilities and joint annual reports. We can obtain that list for you. All right, I'd like to return to this, the Tennessee Hospital Charge Reports posted to our website. And these are available to look at or download in PDF format. The hospital discharge is really useful in analyzing differences in charges by hospital or facility in Tennessee for the same diagnostic categories. And just a quote from one of these reports: the charge listed in the report is the base charge for a hospitalization. It is not necessarily the actual charge made to the patient or his insurer. Nevertheless, the hospital's base charge is useful for comparison, and it is the only generally available figure for making case-by-case comparisons. So you can look at by different hospitals and different severity levels in these reports and see how some of these summaries are made, and can be surprisingly or substantially different in some cases. It's kind of interesting. But if you want to do your own analysis, say on counts and costs by facilities, it may be good to look at some of these reports we have on our website. Example, we only publish, in these reports anyway, Tennessee hospitals having 6 or more cases falling into a particular category. And for the purpose of comparability, certain charges are removed from the reports, like patients with no charge or with a 0 or negative charge. Also, patients that were transferred from an acute care or critical care hospital, patients discharged to a general or critical care hospital, and those patients who left against a medical vice or discontinued their care, they were also removed. So to summarize, if you intend to release our data or make a decision from our data, we ask that you please give credit where credit is due. And we'd also like to receive a copy of your results, just so we have that, number one, to look at, and number two, so we have that on hand if we receive any questions from the outside. So if you have any questions.
Yeah, thank you, Daniel. There is a question for you. How do we identify Medicaid patients? Is any element reliable for it?
There's the payer. There's a payer A, payer B, and payer C variables in our calculated variables. And I think if you look at the payer A, that's primarily what would probably be looked at. And we have an option for if it's a Medicare, was it the question?
Yeah, Medicaid.
A Medicaid, and that would fall under TennCare, be coded as TennCare then in Tennessee.
Okay. Another question. Can you comment on the medical record number? Is the length consistent across hospitals? Nerissa, you could jump into with this one.
The medical record numbers are assigned by the individual hospital. The number may consist of all digits, or it may consist of alpha and digits along with dashes. So it is up to that hospital as to how they assign the medical record number.
Right. Thank you. And there's a question, where should we send a copy of our study results? At the end of the slides, we'll have our contact information. So if you'd send it to the Office of Healthcare Statistics, that'll be great. All right. If Daniel, if you'd stop sharing, we'll come to the last 10 minutes of an open session where you're all welcome to ask questions or use the chat function so you may unmute yourselves. And I will share the last. Daniel, you're still. Do we have any questions? Do you have any comments? Okay, I will open the poll for the last question, and then we will have. All right. I will show this scene again. I'm the host and trying to make sure I catch all your questions. Okay, the question is, we have two questions. Who was the main payer source for inpatient discharges from an acute care hospital in 2018? Who was the main payer source for an emergency room visits for children ages 1 to 17 from an acute care hospital in 2018? So we have two questions there, and we have about a minute, half a minute, 5 seconds actually. So now I think I will allow you to unmute yourselves while when we're done with the poll. Um, there's a question here, if any of the panel wants to answer this. Is HDDS good for estimate primary care utilization? If we're trying to estimate primary care utilization, is it a good estimate? I would not think so because we do not. This is when a person ends up in the hospital. That's when you see them after all primary care and all the other care maybe has taken place or not taken place. So it is not a good estimate for primary care utilization. It's a good estimate for certain prevalence of certain disease when they're like really critical at that stage. But I would not think it's a good estimate. But it might be a good estimate to see where we're lacking in primary care. I mean, if patients don't get the care they need, then they end up in the hospitals. That could be an indicator of that. All right, the polls have closed, and I will share the results. And here are the answers. So who was the main payer source for inpatient discharges for an acute hospital in 2018? It was Medicare, almost 50%. I think that's what the numbers were showing or more. And for the other question, who was the main payer source for emergency room visits for children ages 1 to 17 from an acute care hospital in 2018? It was TennCare, again close to 50%. And I think other insurance followed closely to that. And with TennCare, I think it's not really surprising given the fact that TennCare does cover almost 50% of births in Tennessee. And so it's likely the children continue with insurance going forward from there. So this comes to the end of our presentations, and we have basically about 5 minutes for discussion. If anybody has questions or want to ask anything, the chat function, the Q&A is open for that. How can we meet your data needs? What more would you like to see from us? What is available? Oh, there's a question here. Could patient ID be linked across hospitals and across years? Yes, patient ID is derived from the social security number, so it's a proxy for that. And you could, if that patient used their social security number across different hospitals and years, you'd be able to link that patient over the different visits. Another question is, what do you use to set the emergency indicator? Do you use revenue code diagnosis or procedure codes, etc.? Or is this solely from a flag sent by the institution? I think this one's for you, Brian.
Yeah, so the indicator that would flag a record as being an ED case is based on revenue code. And that's so it's something that we set based on the data that the hospital provides. Revenue.
Okay. Thank you. There's a question, are there plans to update some of the reports online? The last was 2013. This one's for you, Daniel. Daniel Merchant. Are there plans to update some of the reports online?
Well, I don't think we made any decision on that yet, but I think it would be a good idea.
Yes, I think based on the usefulness and feedback we get from it, we're willing and we're able to update those reports and provide additional reports based on your needs. Okay, I think I would like to invite our Assistant Commissioner, Shalini Parekh, to probably wrap it up for us if I can get this to work. Do we have any more questions? Anybody would like to talk before we do that? Shalini, if you could unmute yourself. Um, I'm, do we have any more? Oh, is unable to be unmute. I think okay, there's a question here for Daniel. How can we know a patient who went into 2 different EDs the same day?
The primary way I would know how to do it would be to run a program on the actual data by identifying definitely the same patient And when they were,
Can you please mute yourselves? I had to also like Shalini
Free to give him whatever chance
say
of
something.
improving now if things do not work out with him in the coming weeks. Also, reach out to you to go.
Um, Shalini, are you able to speak now? Sorry, Daniel.
Yes, I'm able to. Can you hear me?
Yes.
Okay, great. I just wanted to say that on behalf of the Division of Population Health Assistance, I just wanted to thank both staff and the participants for being a part of a very quick webinar on the hospital discharge data system. I'm exceedingly proud of the work that's being done by both the staff and through our important partnership with the Tennessee Hospital Association. I think that's about it. Thank you so much again for being a part of it.
All right. Thank you. So we'll just wrap it up with Daniel having a question. You can unmute yourself, Daniel, and answer the question. Then we'll wrap it up. Okay, Daniel.
yeah, what was the question?
The question is, what would be the identifier? You know, when you identify the same ED visits in the same day.
You could look at the social security number for the individual. We also have the date of birth, the gender, make sure all those things are matching up to the zip code, resident zip code, make sure that you're definitely pulling the same person.
All right. I think we're out of time, but basically, I just want to reiterate that our data has a lot of information that other states do not generally have. Like you can have an ID, you have the gender and all this stuff. So it's just almost a really, really, really good data set for you to use for your data needs. So thank you everybody for being with us today. Thank you, Brian, for presenting with us, and hope you guys have a good rest of the day. Thank you, and bye-bye.